body image disorders.
So how do you handle dysmorphic thinking?
I think that's a journey, truly, to feel comfortable with who you are and to be in a place of acceptance.
Even though we're dealing with different things, I think that the core base of the areas of pathology are very similar.
Are we doing something good for people by enhancing those areas of their face that bother them?
Probably both. I think if they were able
question.
to identify the patient population that is healthy sort of objectives and goals.
So what can you do as a surgeon, a facial plastic surgeon, and you as an expert, body expert, how do you navigate this challenging world that we're in now with social media?
I think the social media for sure is an amplifier in all of the same arenas.
I think just maybe some of the confusion that social media has layered on, really actively disordered, is spoken about in such a normalized way.
Hi, everyone. Welcome back to another episode of UnPhiltered. Today, we have a terrific guest with us, and we're going to be covering a different angle and different topic. We're going to be talking about body image disorders, which can be significant in our patient population and affect a broad range of patients seeking cosmetic enhancement and cosmetic surgery. So I'll turn over the mic to Nancy, and I think you'll find this super interesting.
Hi, everybody. So today we welcome Kyla.
Hi.
She is a specialist with eating disorders and body image and dysmorphia. And we thought we would chat about the population of people that perhaps overlap in both of our worlds. People are far more self-critical, far more obsessed with how they look than they ever were before. So I thought I would open up that conversation with Kyla. Tell us a little bit about what you do and the population of people that you see.
Sure. Thank you for having me. So nice to see you guys.
Thank you for joining us.
Yeah. So the center is a now fully virtual comprehensive eating disorder recovery center. We treat people from an individualized perspective across the entire spectrum of eating disorders. So whether that's, acute eating disorders or high functioning in the world and have always been yo-yo dieting or just really, unhappy in your body, to those that are moving through different stages of life and not able to navigate what it feels like to be in your body, the challenges with like messages and images and all of the information we get about like what we should eat, how we should look, all the influences and such. And so we cater to the entire spectrum of anyone who's impacted by food in the body in any way that just preoccupies you, makes you feel badly about yourself, makes you feel like you need to be different, and puts you in very, very different situations or difficult or really harmful situations.
You've been doing this for 20 years, so this is pre-Instagram and Facebook.
Yeah.
So how have you seen things have changed over the course of time?
I just think we have more time to leave ourselves and we have more time to feel connected to things that we can't touch, we can't be a part of. And I think we're way more living in a fantasy and feeling like we're not good enough, our life isn't good enough. And really eating disorders are a manifestation of much deeper things that are going on for people. So I feel like with the impact of social media, we now have an opportunity to sort of separate even further from ourselves.
Right.
And that leads people to really feel like there's a lot they need to do to be different than who they are. Social media plays a very powerful role in our self-concept, in how we feel about ourselves in the world and how we engage in relationship. And I think anything we do that takes us away from ourselves can leave room for harmful behaviors with food in the body.
So how do you handle dysmorphic thinking?
Well, I think there's an important piece, which is, I'm not sure that we always will or should imagine that we would feel so great about how we look. Like, I think that's a journey, truly, to feel comfortable with who you are and to be in a place of acceptance. And so I think that dysmorphia can act as just another form of a preoccupation around, a focus, a distraction, a really consumed way of being and thinking that I think takes people away from maybe some other things that are going on for them at a deeper level. In the same way that our patients at the center, focus explicitly on, what they have to eat, when they have to eat, how they have to eat, and all the harmful behaviors of binging, purging, and restricting that they have to move through. Those preoccupations and intrusive ways of being and thinking is similar to like looking at yourself and seeing something and feeling like it needs to be different and it needs to be changed. And if that could be possible, then you can have this fantasy of what your life might become if that thing was different. And I'm not really sure that anything could ever be enough if that is the thing that we require to change. I don't know, and you would know obviously better than I would in terms of if someone's so focused on a particular feature, if it changes, do they truly reach the fantasy that they think they will? And I think the same is true when it comes to the body. Like, I will be better. I will have the full and rich and exceptional life that I want if my body looks a certain way. And people have gotten to those places and they're not happier. They're not content. They're not fuller. They don't feel richer. They don't feel better because they're still them. Dysmorphia is just another entity of preoccupation in those ways.
How much of that is anxiety, obsessive compulsive thoughts or behavior?
Probably very much so. Mm-hmm. Yeah, I think the ability to fixate on something and to become consumed by something is, often very much connected to obsessiveness, compulsiveness. Mm. Probably what we see with dysmorphia is that it doesn't get resolved, even if that thing is fixed or changed. I think what we notice is that it just cycles to a new thing.
Right.
We see that.
Yeah.
And I bet you.
Well, it's amazing. Every word you said, I felt like I could insert in my practice in terms of cosmetic surgery. So even though we're dealing with different things, I think that the core base of the areas of pathology are very similar. And again, hopefully the majority of the people that we're taking on as patients are doing it for healthy reasons to enhance something that bothers them, but they're not in that preoccupation, obsessive compulsive desire to be different, to fix something that's wrong in their life. So I think the area, probably there's a big area of overlap with the gray where patients seek cosmetic enhancements or have body dysmorphia or have issues with their weight, and they become all-consuming, obsessive, a way of self-control, to different manifestations of very similar underlying deep psychological issues. The problem is it's hard to always pick up on it before we become involved with them as a patient. And sometimes we fix one thing and it's not enough. And then we fix something else and it's not enough. And again and again, it just becomes a perpetual thing where we're not achieving results of happiness and contentment. So it sounds very, very similar.
Because it doesn't give that person the fantasy that they have come to believe will happen for them, in the same way that if we're dealing with a client with acute anorexia, the reality is, like, if my weight reaches this low point, I will be enough. And that goalpost continues to move more and more and more and more because you never can reach that point. It's not going to resolve the deeper reasons why someone feels the way that they feel about themselves, whether something's fixed or not.
Yeah, so people use the term narcissism when it relates specifically to beauty and looks. And if you look up like the story of Narcissus, it's interesting because it's a Greek story of a figure, a narcissist, who's looking into the pond and sees a reflection of themselves, but they're not falling in love with themselves, which is how people use it in casual conversation. They're falling in love with the image of themselves, which isn't real. And again, it's the same sort of idea. They're chasing that image. Mm-hmm. So it could be use of weight loss, cosmetic surgery, I don't know, clothes, watches, cars, anything, stuff to make them feel that they look like the reflection. And then social media is another example of that pond. And so you're seeing now the filtered version of yourself. You're falling in love with the filtered version. You're morphing yourself. You're falling in love with the morphed version, the filtered morphed version. So, again, it's all the same concept, but it's just extended now.
Yeah. And the curated version of your life. I mean, everybody puts only the best things out and everyone's lives look really put together and, grandeur and, better than you could ever imagine, like as though that's possible for everyone. And I think it makes people feel like they're small and they're not good enough. And there's way more for them to be doing to reach those heights. So it just feeds really low self-concept, which is really at the root of eating disorder behavior too. Just, not feeling like enough, not feeling worthy, not feeling valued.
So in the cosmetic surgery world? Are we reinforcing those thoughts, or are we doing something good for people by enhancing those areas of their face that bother them?
Probably both. I think if they were able to identify the patient population that is healthy sort of objectives and goals, then we see all the time patients get a procedure done. They're thrilled with it. It's enhanced their self-esteem. Mm-hmm. They're no longer bothered by, say, a larger nose or a saggy face or bags under their eyes. Those are definable things that potentially they're not happy with. You come, you make a plan, you have the procedure done, and hopefully you like the new you. The pathologic version of that is everything we're talking about now, where you're never going to be happy no matter what procedure is done. And it's not the majority of our patients, a small minority, but those patients are sticky, we call them. We see them, they stick around in the practice, and they're not necessarily getting to the point that we're feeling that either we've made them happy or they're not happy with the result. And it can be very, very challenging, especially if the result's good.
Mm-hmm. We see that. I mean, it is tricky because we meet people in consultation. Sometimes we can get a sense, or sometimes over the course of when they decide to book surgery and we get to know them a little bit better, but you also want to help them. So that's the tricky part, because you have to navigate, is this a good relationship to enter with surgery because I want to help them, or am I going down that rabbit hole of this is just self-fulfilling criticism that they keep, going through?
Well, to make it even more complicated, you see a patient, you don't know their psychology that well. You do some type of assessment and get a sense of it, but you still may see the physical problem that they're bothered by, and you think that they're physically a candidate for the intervention. You do the procedure. You may have overlooked or maybe not picked up totally on their obsessiveness of this obsessive nature or compulsive nature of their personality. You do the procedure and it goes perfectly well. They may not be happy. But what if it doesn't go perfectly well? That can happen as well. So you now have a patient who's psychologically not happy no matter what you do, and they may have an issue with the result. So you then intervene again to try to give them a better result. They're still not going to be happy, but each time you do the procedure, the risk profile changes. So you're working now with a very dynamic and very stressful environment where you have a dissatisfied patient, complex physical situation where you're trying to remedy it. So you end up in this sort of loop. Mm-hmm. And we see that from time to time. But again, it's a minority of our patients. And, we do our best to be as compassionate as possible. We don't want to label patients, oh, you're crazy or you're obsessive. I mean, that's the last thing we want to do. But at the same time, we can only offer what we can offer. We can be supportive and provide the best skills that we have and our ability to try to get them to the point that they're happy, but it's sometimes impossible.
As a therapist, what would you say to a patient in those circumstances? Do you have any advice?
In terms of feeling never satisfied?
Exactly.
I mean, I think we see that all the time too. There's people who come into the center and they're so desperate to be freed from the intrusive nature of the eating disorder and the rules and rituals that they have to follow, and would do anything and everything to have the freedom and a free mind and, free space. But also the truth is like, would you let go of the thing that you've been held hostage by, that has formulated the way that you operate in the world, that you've become so accustomed to following, despite the fact that it feels so imprisoning? It's also terrifying. And so maybe that's also part of it. It's like you see the thing that you've been seeing for so long and you realize you maybe don't like it. But then when it changes, you wonder, like, do I like it better? Is it enough now? Have I gotten the thing? Like, I'm afraid to not have what I didn't like it was familiar in a way. I think newness is very scary too. And I think that also sort of leaves people feeling like there could be more, or the fantasy could be reached if I just keep going. I mean, I think that it's very, very hard to navigate people who would feel unsatisfied. I can't imagine what that would feel like. I think in our own way, being in a safe relationship with food and your body and yourself comes from sometimes, I think, looking away from the external. That's such a hyper focus when you have an eating disorder, is like your appearance and what's happening to you physically. And I think that there's a really important opportunity to figure out how to connect more inwardly, to see if, why you actually really are unhappy, if so, or what would really satisfy you. And sometimes that may mean I got to get my nose done. That may actually be that, and that's great if you come to that. But perhaps the never ending cycle of being unsatisfied is because that's way, way deeper. Nothing could really repair that on the outside, because it's clearly, at least, when you're sharing your story, it's like, obviously there's something happening to that person more deeply that nothing on the outside could really change that. Not enough surgery, not enough stuff, not enough.
Interesting. We see patients that come to us. I hear their stories probably a little bit more just because I do the consultations, and they come to us later in life. You can tell the ones that are looking to surgery to really fix something, change their life, change the path. And quite often it does. They come out feeling better. They're holding their heads up higher, and they thank us for, empowering them to feel good about themselves, which is interesting because, it can go either way. But I do think it can be super helpful too.
I think again, healthy psychology, if the expectations are set and if the reality meets their expectations, then everyone's happy. It's when the reality doesn't necessarily meet the expectation. Now, that expectation we can't control. If the expectation is unreasonable, unrealistic, fantasy world, then we'll never reach that expectation. Then you get a dissatisfied patient. That rule of expectation versus reality defines happiness in general, all aspects of life. So I think with cosmetic surgery, we see it. Reasonable person, reasonable expectation, surgical outcome maybe exceeds their expectation, super happy. Reality falls short of the expectation, dissatisfied patient. Now that's different than pathologically obsessive. That's sprinkled on top of all of this stuff. That's like in the healthy world.
But really an incredible gift to be able to treat a person and have them leave and feel like you've really improved the quality of my life, because this thing that I have been so fixated on that now is changed for me. Like you've opened up a window to make me feel like who I really know I am and how I can be in the world differently. That's really an incredible gift. So I think sometimes there's this idea of like, I know in my world, at least when it comes to eating disorders and like acceptance of the body and, being in relationship with food, it's like you should just accept like what you should just accept whatever will happen if you could just be free with food and, if you don't have this. But there is a standard that people also want to be held up to, which is like liking the way that they look and feeling comfortable in their skin and like waking up in the morning and being like, I'm really good with this, whatever that may be. And so I feel like there's sort of a space in eating disorder recovery where that's a really important acknowledgement. And I imagine with your patients, that's an unbelievable experience.
Oh, for sure. This job is filled with tremendous gratitude from patients, and we feel tremendous satisfaction when the patients' lives are changed for the better. So that's the best part of the job. Yeah. The most challenging part of the job is the other side of the coin, where we're falling short or the patients aren't happy. And fortunately, the majority are in the happy camp, but the minority can certainly cause a lot of stress for themselves as well as their family members and us as well. So every plastic surgeon, when we go to meetings and we talk, these are sort of topics that are put up. We had, I remember going to a meeting in New York City. I used to go every year. It was like a famous meeting, and they had a tremendous, talented surgeon speaking at this meeting. And there was an older surgeon who put up a bunch of slides, and he said, and they were like amazing results. And he said, I wanted to show these slides, and these patients are all my least satisfied patients. They all are not happy with the result. And he would go through case by case, and he had archived them perfectly. So he could be, the whole audience could be critical, and they were like beautiful results. Wow. And then he would say these people would have basically like unrealistic expectations. And some of them caused him tremendous anguish and stress, enough that he put this on he had to talk about it. He had to have his own personal catharsis putting it up on the lecture circuit. But it was one of those lectures that I found super interesting as a younger surgeon. It was like 20-something years ago. He was like a world famous nasal surgeon. And, he felt the need to sort of go on the circuit sharing this with people because it's part of the nature of this job, dealing with complicated issues. And then people will say, well, certainly you can screen for it, but we have patients who have like, in the DSM, there's different categories of psychiatric, description of psychiatric illnesses. And, in Axis 1, like patients, and I think it may have even been updated since I studied psychiatry, but in Axis 1, you'd have patients with schizophrenia, bipolar, depressive, depression, things like that. Then you had a separate category for personality disorders. But we've had patients with significant anxiety and significant depression on Axis 1, who we've asked their family doctor or psychiatrist to okay them for surgery. And we've operated on them with that type of sort of strategy. So we're inclusive of their family doctor and psychiatrist, and they've loved the result. It's changed their life for the better. So when I trained, we were told to avoid those patients, but probably more than like a third of our patients coming through the door ticking off some stuff about anxiety and depression. So it's not really, you can't just simplify it to that. And then we find people who have no Axis 1, who don't even know they have an Axis 2, say, and those patients can be tremendously challenging because they probably have underlying stuff, maybe never really diagnosed with it, either be narcissistic personality disorder, borderline personality disorder, thrown in with a bit of anxiety, maybe some obsessive compulsive thoughts, and they can be very, very challenging because there's not always a easy way to remedy those things. Some of those things are perpetual things throughout your life you're working through.
And the readiness to do something so permanent is, I don't always know if we could really understand what that means. I imagine like we think we want to change something about the way that we look. And then when we do, I don't know if you could always anticipate what that could mean for someone.
Right.
How they'll feel about that permanency. It's quite significant. There's no going back. That's what's so interesting. Probably the difference in my work is like what I could say to people is, you could try on recovery for a bit. You could see if you like it. We could work really hard and you could see how your freer space in your mind and your life could really change things for you. And in reality, you can always go back to your rules and rituals that have really robbed you of so much. But, there is that thing that it's not permanent unless they keep working hard at it. But there's something so interesting about your work that's so permanent. Even
in our world, the things that aren't considered permanent, like injectable fillers, can be somewhat permanent.
Yes.
We were just talking about that.
Yeah.
Well, the whole industry was told that they're not permanent. Now everyone's saying, well, they kind of are maybe a bit permanent.
Yes.
So it's interesting. But
yes.
That was sort of like the entry level stuff that we would say, okay, well, we could try this, try that. And if you don't like it, but nothing's really like totally reversible. You're always taking some like significant step forward, no matter how simple it is. I guess Botox would be the only thing that really we know is very high safety profile.
Right.
Although in the news last week, I think there was someone on a ventilator from Botox, but
oh, wow.
Yeah. Well, I think they got like some illegal black market Botox. So probably not the normal Botox that's being bought.
So what can you do as a surgeon, a facial plastic surgeon, and you as an expert, body expert, how do you navigate this challenging world that we're in now with social media, which I just think must make both industries far more challenging because people, modify their image or they bring in pictures of people they want to look like or be like. And it's just, I find it to be, I've got daughters and I just think it's a challenging world. Mm-hmm. So it makes, your industry probably busier, yours busier. And
I think the social media for sure is an amplifier in all of the same arenas. I'm sure pre-social media, all of these issues were still around. They just become amplified with the social media. But I think the same sort of things are required, as a healthcare professional where, good history, diagnosis, assessment, provide the risks, determine candidacy, try to not operate on people that you think it may not serve them or you well. Some of the red flags that we look at, we've talked about red flags, I think, on another podcast, So
how does somebody at home know if they are a red flag or if they have healthy thinking? How can someone sort of diagnose themselves to know if they should come your way?
It's tricky, and I don't know if people always have the wherewithal or the insight to really know if they're healthy or not. A lot of these are abnormal thought processes, which, are sort of swirling around circles. So they're not necessarily going to step back and say, oh, I'm not going to do that. The odd person who's being treated, say, for OCD, and they know they have OCD, likely may step back and think, I'm not really going to go down that road of getting a nose job or a chin implant or something, because I may be terrified that I start obsessing about it and don't think it's a good idea. But we do see people with OCD who get cosmetic surgery who are completely fine. So it becomes it's not always straightforward. So we're always happy to assess people and be honest with them and tell them what we think and tell them if we think they're a good candidate. I think support systems are very important. I think, we can do whatever screening we want, but younger people who have, hopefully a good family support network, people who are the best are people who have like supportive parents who are educated and aware of their child's issues. To support them through the process often is tremendously helpful. But if you have someone without the support systems who suffers from OCD, who's it's sometimes self-evident. We may tell them, hold off till you're a bit older before you make those decisions. When we see people in their early teens obsessing about their nose, they don't show up with a parent. They say their parents don't know they even want to have surgery done. We've seen that a bunch of times. Then we're saying, even though legally they could sign a consent in Ontario, even at that age, we wouldn't operate on someone like that. We would say, please bring in your parents, even though it's your own personal information. We just don't feel comfortable proceeding without some support. We don't want people hiding stuff from their family members. Mm-hmm. That would be a red flag, I think.
I would agree. Mm-hmm. Anything else you'd like to add from your point of view?
I think just maybe some of the confusion that social media has layered on with people when it comes to eating disorders now is just so much that is really actively disordered is spoken about in such a normalized way in terms of like what you should do with food or how you should exercise, just like all these normative concepts around, what I eat in a day or all these things that we look to influencers to give us information about. Mm-hmm. And they really are highly disordered behaviors and they've become normal. And so I think what it's done is it's distorted truths about how to be in relationship with food in your own body versus what someone else may be telling you that is really very much on the spectrum of eating disorders and disordered eating. And I think, probably most every person has some element of disordered eating that if not for eating disorder behavior, which is like really in and of itself a very blurry line. But I think everybody struggles with rules and rituals that they feel they have to follow. And social media has become this, this arena that supports so many of these harmful behaviors, even as simple as like, certain food groups that you shouldn't eat or times that you should or shouldn't eat or, do it this way and not that way or move your body like this, all this stuff that I think we look at on social media and say like, oh, this is what's normal. This is what I should do. It's actually quite disordered. Yeah.
Challenging.
I have a question.
Yeah.
It seems as if so many people are now doing what they call microdosing of this GLP-1.
Yes.
And so how do you see that in your practice? Where they've normalized the medical intervention that was made for diabetes, obesity, and and the criteria is sort of like set and keeps changing and evolving. And then people are using it almost as a supplement for aesthetics rather than for health indications.
It's a very complicated issue in my world, and a really important one. I think that there's a very important place for a GLP-1 for certain people. But I also think what is being missed is that so many people who are using GLP-1s are actively eating disordered and have disordered eating. And I think, again, it becomes this sort of top-level intervention that doesn't ever deal with all of the inner workings of why a person is in so much harm with food and their body. And so I think that we work with a lot of people who have been on GLP-1s and come to us because they still don't feel good. Their bodies may be shifted, but all the things that that have festered inside of them that they've never confronted, they haven't gone away just because maybe there's been weight loss, or even when there's been weight loss, there's not satisfaction. It's so complicated. I think that it's a very challenging treatment for someone in my world. And I think also it's an important one for someone in my world, depending upon where you may land on the spectrum. Like ultimately, I feel really in support of people liking their body and being in relationship with their body and liking themselves. I think there's a myriad of ways that we can go about finding that and feeling that. I think that there's probably a lack of true internal honesty around what we're seeking when we make decisions around taking a GLP-1 in a microdosing kind of way. You know, in the same way that someone might restrict all their food because they want to fit into the dress for the wedding. It's the same concept. And I'm not sure that relieves a person. They might get into the dress at the wedding, but the rebound might be binge eating and purging and feeling uncomfortable. And I just think there's a lot of things that we haven't considered about what that access does to people.
I'm just amazed at how much overlap we have on this topic. So I hope everyone listened in. That was a lot of information. I found it super informative for myself. I think there was a tremendous amount of overlap between the issues that we deal with in both of our practices. And I want to thank you for participating in our podcast. And thank you all for listening in. And we will see you again, another episode of UnFiltered.